All right, number one. What are the two AV blockages that we have to put a pacer in? Good. Sam says Mobitz 2 and third degree. Okay, everybody agree with that? Yeah, I think the picture's getting stuck or the voice is getting stuck a little bit. Okay, let's hope it's okay now. Okay, all right. Describe first degree. First degree block. PR interval over 0.2. Very good. Good. Sam said it even better. Prolonged PR interval over 0.2 without other abnormality. Right? Everybody okay with that? All right. Second degree type 1. Second degree type 1. Good. Prolonged, continuous prolongation of PR and predictable dropped QRS. Every third, every fourth, every fifth, something like that. Okay? So you should see PR interval increase, PR interval increase, PR interval increase. P drops the QRS. Starts from the beginning again. Okay? Everybody okay with that? Should I be worried about that? No worries. Okay. Everybody okay with that? No pacemaker, no worries. Okay. Second degree type 2. Good. Fixed PR interval, right? And then random dropping of QRS. Right. Be careful about PR interval may be normal or may be increased, but it's fixed, right? It's fixed. That's the important thing. It doesn't change. It doesn't get wider, and then all of a sudden you drop a QRS. Okay, that's type 2, second degree heart block. That needs a pacemaker. All right, Sam says, get a cardio consult. You're absolutely right, because they are going to put the pacemaker in. Okay, now tell me about type 3. Good. P waves occur at regular intervals between themselves, right? QRS complexes regular between themselves, but there's no correlation. Total disconnect between the P and the QRS. Okay? So asynchrony. Okay? Everybody okay with that? All right. What do I do in the third degree heart block? Pacemaker. Okay. Guys, which one out of all the 4 blocks that we just talked about, which is the only one where the QRS complex is enlarged? So it's over 0.12, which is 3 boxes. Only third degree. right? Let's keep it simple. I know there's some types of other weird blocks that you could get it, but let's keep it simple. They're not going to ask us crazy stuff on step 2. Okay? All right. What in type 3, third degree heart block, what is the idioventricular pacing? What are they usually paced at? 20 to 40. Remember, it's really slow because idioventricular pacers are really slow. By definition, they're really slow, and they're even slower because they can't pace through the conduction system. So they use the muscles to pace, which takes a longer time, and that's why the QRS complex is wide. Okay? All right. Let's talk about some tachyarrhythmias. I want to talk about a flutter and a fib. All right, tell me some things you guys know about a flutter. Sawtooth pattern, right? It's not so nicely evident in this one. It looks kind of like this, right? Kind of like this. Okay? All right. Other things you know. Narrow complex tachycardia. Very good, Sam. Why? Because again, it's supraventricular, right? I always look at the QRS complex. Good. Tricuspid annulus, right? And do you guys know about this? What Asa's talking about? So these pacemakers are usually around the tricuspid annulus and the pulmonary veins. Well, this was a great article about 6-7 years ago where it looked for these pacemakers around the tricuspid annulus and the pulmonary veins. So why is that important? Who cares? Ablation point. So your friend, the electrophysiologist, that goes in and they ablate them, and it's curative. Okay, what else do we know? It's an unstable rhythm. What do I mean by unstable? I don't mean it makes the patient unstable. It can make the patient unstable. It's an unstable rhythm in that you don't have atrial flutter forever. You could have AFib for 50 years, right? But atrial flutter either goes back to sinus rhythm or to something else like AFib. Okay? Everybody okay with that? All right. Last thing about a flutter, very important. It's the one, it's the the rhythm where I could convert back to sinus rhythm with the lowest amount of current. All right, so what am I talking about here? What type of current? What am I talking here? Cardioversion, right? I could cardiovert these guys. I shock these guys back into normal sinus rhythm, right? Sometimes I only have to use 25 joules and I could get it back to normal sinus rhythm. And then lastly, studies now we know this is the prime rhythm for electrophysiologists to basically go in there and ablate these ectopic pacemakers. Where did we say these ectopic pacemakers are located? Pulmonary veins, tricuspid annulus. Okay? All right, so look at this now. So here's the difference. Here's the atria, right? the right and left atria, right, and kind of go into the ventricles here. All right, in flutter, right, you have one ectopicus pacemaker that has taken over, right? That's why if I measure the QRS complexes, they're regular, right, pretty much. Because even though it's going really fast and I can't see P waves and they look like sawtooth patterns, this pacemaker, one pacemaker, has taken over everything else. So atrial flutter, most of the time, is regularly irregular, they call it. Right, now look at this. Here's AFib. AFib has multiple pacemakers that are activated. Again, in the pulmonic veins and the tricuspid annulus, they all shoot off, right? All these guys, they're like all over the place. And depending on the refractory period, depending on where you're at in the refractory period, and when one of these goes off, it may go through, it may not. That's why AFib is irregular most of the time, right? It has to do with the number of pacemakers. Okay? Everybody okay with that? All right. For both AFib and aflutter, if the patient is unstable, clinically unstable because of the rhythm, right? Because it's going too fast, because your heart is going at 160 and you can't take it. What is always the treatment? Shock. What's another nice way to say shock? We cardiovert them, right? We cardiovert them. Synchronized cardioversion, right? What's asynchronous cardioversion? When do we do that? There's a role for that too. Refib, because we can't do synchronized cardioversion. There is no synchrony, right? Everybody okay with that? Okay, very good. A 43-year-old man is evaluated for palpitations. He has no prior history or no prior personal or family history of cardiovascular disease, diabetes mellitus, or hypertension. His cardiovascular examination is unremarkable, with the exception of an irregular rapid heart rate. Lung examination is normal. Laboratory testing, including thyroid function, is normal. So be careful about thyroid function. Okay? New onset tachyarrhythmias, aflutter, and AFib, thyroid function has to be investigated. Okay? The chest radiograph, okay, is normal. The EKG is shown on the next slide. Oop. What do you guys think? Now, you guys know enough from reading bradyarrhythmias to kind of figure what this guy's got, believe it or not. Okay, I know some of you say, well, students, EKGs and stuff like that. You guys know this. You could figure it out. Good. So Yusuf and Jasmine say this is likely to be AFib, right? It's irregular. I don't see the sawtooth patterns. And what else don't I see? I don't see any P waves. I just see like this irregular wave going across. Okay? Now look at this. Follow the QRS or RR. What do you guys notice here? See, that's why I gave you that definition. I gave you that definition, the difference between flutter and fib, right? What do you notice between the R distance here? Is it stable? Well, it's not, because here's like the difference between the first one is like 3.5 boxes, and the difference between right here is like 7 boxes, right? Everybody see that? So what does that mean? You have different pacemakers going off. And depending on who goes through at a different time, you get a QRS complex. Okay, so what does this patient have? By definition, what's the tachyarrhythmia that you can't see the P waves? The QRS complexes are irregular. It's AFib. All right, let's just make sure here everything sounds good. I look at the QRS complex and it looks normal, less than 0.12, less than 3 boxes, right? So, okay, I'm good. It's from above the ventricles. Okay? Everybody see that? Everybody clear? Okay. AFib is the most common sustained cardiac rhythm. So the magic word here is sustained. Because what did I tell you about a flutter? See, these are the differences. Slowly now we're kind of looking at one disease, comparing it to the other. It is temporary. It's not sustained. I said stable. That's not the right word. It's sustained, right? It is non-sustained. You don't have chronic A flutter, right? That's not stuff that we know of. It may happen in some weird situations, but usually A flutter is for a short time, and then it either changes to another rhythm or goes back to normal sinus rhythm, and back and forth a lot of times. Yeah, that's the problem. You could do an EKG on this guy and it could be normal, and then the next day he has flutter, and then he could go to fib. AFib is sustained. You could have AFib forever. Okay? AFib is associated with structural heart disease. All right, so what happens with heart disease to cause AFib? Atrial dilatation. See, when atria dilate, they activate those pacemakers in the pulmonic veins, the tricuspid annulus area. Okay? Everybody okay with that? Yeah. So I got people with AFib that have had it for like 30 years, believe it or not, which goes to some other questions they ask about that. So atrial dilatation, right, puts people at risk for AFib. Okay, now look at this. So tell me some diseases that dilate the heart, and specifically the atria. Good. Mitral disease, stenosis and regurg. Very good. Because then there's pressure on your atria. Dilated cardiomyopathy, hypertension, really any cause of heart failure, but especially valvular disease. Okay? Anything that stretches the atria. See, stretching of the atria activates these pacemakers. That's the concept. Okay, well, so we see it with heart disease, and it's important to look for heart disease because if you have structural heart disease, whether it's from hypertension or heart failure or any cause, that type of atrial fibrillation, right, is usually very, very hard to non-sustain, to break and go back to sinus rhythm. See, that's why looking for structural heart disease with an echocardiogram is mandatory in AFib. You have to know how to manage this patient, and knowing what's going on with the structure of the heart tells you how difficult to get that patient out of AFib is. Because AFib sometimes occurs with non-detectable disease. They call this lone atrial fibrillation. Lone atrial fibrillation, like the Lone Ranger. It's alone by itself. Okay? Everybody understand that? So who do you think you convert back to sinus rhythm and sustain them back in sinus rhythm? Is it the person with heart disease, structural heart disease, or is it somebody with lone atrial fibrillation, or is it somebody with flutter? Right? Of course, the people that don't have structural heart disease, it's better. People that have non-sustained cardiac rhythm, it's easier. Okay? Everybody okay with that? All right. So here's the other thing that we have to know about AFib. It's associated, right? So AFib patients will revert back if they have structural heart disease, but if they have no detectable heart disease, right? Well, sometimes you can get them back to sinus rhythm and keep them there. Okay, not all the time, but sometimes. Okay, what AFib is also associated with is thromboembolic events. So across the board, it's about 5% per year. That's across the board. But look at this. If you do this scoring system, you guys know about the CHADS, 2 vascular scores, etc., like stuff like that. It gives you the risk of thromboembolic events with AFib, right? So if you have heart failure, you get a point. Have hypertension, you get a point. You are over 75, people that are older, their hearts are different. You get 2 points, right? If you have diabetes, you get a point. If you've had a stroke, you get 2 points, right? So somebody that has 9 points on the CHADS 2 score, 9 points, their risk is over 15% per year. Stroke risk, thromboembolic disease, right? So it's 5% across the board in everybody, but you could tell depending on the scoring system, the points you get, you're higher or lower. Somebody that has 0 CHAD 2 score or 1 point, their risk is like 0% or 1%, right? You probably don't even have to think about anticoagulating. Okay? Everybody okay with that? So thromboembolic events are very important here. All right, so they asked the question, can people live with AFib? And do they have the normal lifespan as other people? The answer is yes, provided what? You take care of this. Okay, they can live forever. That's the point. So AFib by itself doesn't increase mortality and morbidity in these patients. It's the thromboembolic event. So if you take care of that, you give them the appropriate anticoagulation to reduce that, then these people could be in AFib forever. So what's the bottom line? We don't always have to try to get people out of AFib, right? So 20 years ago, right, so they wanted, to get them in the right rhythm, in the right rate, right? Wanted to get them out of AFib and control rate at the same time. Okay? All right. Sometimes AFib in young people can present out of the blue, and it could be part of Wolff-Parkinson-White syndrome. Please be careful of that. Okay, look for the delta wave. Sometimes they're hard to see when somebody is going at 160 per minute. Okay, but why is this super important? Because if you give them regular medications like beta blockers, things that we give in AFib, what do you actually do to people with Wolff Parkinson White? It makes it worse. You block the regular pathways more, and they have access to the fast pathways. So I had this young guy, he had AFib, and we put him, I think it was calcium blockers or beta blockers, and his heart rate went from 120 to 170. Okay? So be careful about that. If they give you a case of AFib where you give them medication and the AFib it worsens, the rate becomes faster, right? You have to think that maybe this is linked to Wolff Parkinson White. Okay? All right. So the CHAD score, right, which now is called the CHADS vascular score, right? This is very important because it allows us to assess CHAD2. So this is the newer one. CHAD, because you get 2 for age if you're over 75. Diabetes, CHADS, right? S2 is stroke, and if you have vascular disease and you're female sex, you get 1, right? So this is the more complex score. You don't have to know all of these, but look, the CHAD score is used to determine whether treatment is required with anticoagulation or antiplatelet therapy. Most people prefer anticoagulation with Coumadin or something like that, right? A high CHAD score puts you at greater risk, right? So the CHAD score, if you want to remember just the basic CHAD score, you could do that. But if you want to know a little bit about the more complicated formula, which all the students and the residents now have in their, in their smartphone anyway, so it's not a big deal, right? C is for heart failure. H is for hypertension. All this stuff gets 1 point. A2 is age 75 or over. That gets 2 points. So the aging heart, there's something up with the aging heart that puts people at risk for thromboembolic disease. Diabetes gets 1, right? Prior stroke gets 2. Vascular disease gets 1. And sex, female sex, gets 1. Okay? Now I told you, right? It could vary anywhere from 0 points, which is like less than 1% chance per year of stroking out, to what? So I said somebody gets 9 points, the risk is 15% per year. That's a humongous, risk. 15% per year. Some of these people, will have it, will have AFib for like 20 years, right? So you think about like 15% per year. Okay? Everybody okay with that? So use the CHAD score to tell you if you have to anticoagulate this patient. Okay? All right. Here's your workup. Right? You do the EKG to confirm. Right? Okay. We know that. I need an echo. The echo is the most important test after the EKG in the workup of atrial fibrillation. Right? Everybody see that? Why? I can see what's wrong with the heart. If there's nothing wrong with the heart, I say, okay, this guy is a good candidate to try to revert back to sinus rhythm. If I see 4-chamber dilatation, this guy's got valvular disease or other things are going on, I'm going to be less aggressive. And I'm going to say, let me just control his rate and keep him in AFib and anticoagulate him. Okay? Everybody okay with that? The echocardiogram also rules out a very important valvular disease that commonly presents, the first time it presents sometimes with AFib, and that's mitral stenosis. Okay? So the two things I have to think about and rule out right away is hyperthyroidism and mitral stenosis. Okay? I also have to get a chest x-ray, right, to make sure nothing else is going on. In the lung, there's nothing else going on around the heart and so forth. All right. So here's your management of AFib. Okay? The most important thing is rate control. And we do that with either a beta blocker or a calcium channel blocker. Diltiazem is a very common and good calcium channel blocker where I could do rate control. Digoxin, I've underlined this because digoxin is the drug of choice in people that have AFib and significant systolic heart failure. Right? So why? Because I could take care of the heart failure and I could take care of the rate control at the same time. Right? So don't use digoxin unless this person has heart failure and AFib. Okay? Now, some people say, look, I did the echo, I found 4-chamber dilatation. Right? Okay, I'm just going to rate control. Right? Just rate control. Okay, I go to this guy and I tell him, look, Mr. Jones, we got good studies. You could live with AFib forever. Okay, but then remember, if you're going to only do rate control, which is totally fine, that's what we most do in most patients anyway, then you have to anticoagulate. So a combination of rate control and anticoagulation, if it's indicated, most of the time it is. Rate control means I give enough of the beta blocker or the calcium channel blocker to keep the rate around 70, at the most 80. You want to slow down the heart. Why do you want to slow down the heart? Because remember, when you have AFib, you've lost what? Your atrial kick, that 20%. So if you have AFib and now your heart's going fast and you've lost that atrial kick, that 20% of volume that you get with your atrial kick, all right, now you don't feel good. You feel short of breath all the time and you can't exercise. So that now I give you calcium blockers or beta blocker and I reduce your heart rate to 60, 70, at the most 80, and now you get better feeling and you don't have any symptoms. And at the same time, you're taking the anticoagulation, right, Coumadin, to reduce the risk of stroke. So this person could be, going on forever. Okay? Well, listen, there's no. So Rudy asks a good question. What is the best anticoagulation drug? So the drug that is used worldwide for anticoagulation, and it's not going to go away anytime soon, is Coumadin. Why? Because Coumadin, even though it's less precise and people are more at risk for bleeding than some of the newer agents, let's take rivaroxaban, for example. Rivaroxaban costs $400 a month. Coumadin costs $1.25 per month. So it ain't going to go away unless these drugs really start coming down. Okay? So that's another good question. Do I have to do a heparin bridge here? And the answer is no. Remember, these are not people that have hypercoagulable states. Now, listen, if this guy, one time we have this great coagulation specialist who actually was a mentor of mine and now works with us, and this guy did an assessment, did a CHAD score on a patient. This guy was off the wall, off the charts. He scored like a 10 or something like that. And he said, look, put him on heparin, and Coumadin, because this guy, until you get him Coumadinized, your risk of stroke is very high. Well, the team didn't listen to him, and the guy threw a small stroke. Okay? But listen, AFib in general does not need a heparin bridge. Why? Because AFib is not a clot. It's not a hypercoagulable state. See, what are you worrying about? People that throw clots have protein C deficiency, and if you give only Coumadin and you don't give heparin, you're going to get Coumadin skin necrosis. Plus, the clot's going to propagate the first 5 or 6 days until you get Coumadin to therapeutic levels. So we don't have the same situation here. So most people say, look, it's okay, just start Coumadin and make it therapeutic, and then you're okay. Okay? Except for certain very rare scenarios like the one I told you. Okay? Everybody okay with that? All right. What if you decide to do rhythm control in this guy because he wants it, right? Because he doesn't have structural heart disease, because you want to try and maybe to get him in rhythm control? There's a lot of reasons. Okay, here's your choices. Okay, synchronized cardioversion, right? Bring him in, right? And you shock him, right? You shock him back to sinus rhythm, right? Or you could put him on amiodarone. Amiodarone is a good drug. Or if everything fails, you still have catheter ablation, right? Those are your choices. Okay, be careful about amiodarone. They've asked side effects because we're using a lot of amiodarone now. It's a lovely, antiarrhythmic agent. Doesn't, have as proarrhythmic effects some of the older one does. But look, it has side effects. Okay, can you guys tell me some of the side effects? Good. Pulmonary fibrosis, hyper and hypothyroidism. Okay, very good. Hepatotoxicity, right? Very good. Anything else? You guys ever see the skin in people taking amiodarone for a long time? Kind of dark, grayish looking, right? Anybody know the half-life of amiodarone? 60 days. You're right, Mary. 60 days. So look, if you get a side effect and I stop it, right, half-life is 60 days. It's going to take a long time to get out of your system. Right, which is another, listen, for some people, like the cardiologists like that, right? Because somebody misses a day or two, it doesn't affect them, right? Doesn't have short half-life like some of the other medication, right? But there's also a bad side to having a long half-life. You get side effects, it's going to take you a long time to get them off the medication. Okay? So these are your choices right here. Okay? Everybody see that? All right. If you're going to do rhythm control in this person, you're going to try to synchronize them, right? So do cardiovert them or pharmacologic cardioversion, right? Please, these people have to be on anticoagulation before and at least have an echo. Make sure they don't have a thrombus, right, in the chambers. Okay, you just don't go straight to doing this kind of stuff. This patient needs a workup before. Okay, and these are elective. Okay, everybody okay with that? All right, so listen, let's take a couple of cases now and work them up so you guys understand what the story is. All right, so now I have a 43-year-old guy with no past medical history, who comes to the emergency department with AFib, right? The heart rate is very high in the 160s, okay? This patient is diaphoretic, right? And his blood pressure is 70 over 40. He has cold extremities. It doesn't look good, okay? So one of the things you have to think about, like Mary said, he's relatively young. He could have Wolff Parkinson White, right? But he didn't. Okay? Good. So the question is, what is the next step in management of this patient? And Sam already answered that, right? The answer is cardiovert. Okay? Everybody okay with that? Everybody clear? So listen, if the patient is unstable from the rhythm, there's only one option. Okay? Recardiovert. Okay, and then put him on medication that's going to control his rate, right? Like calcium channel blockers and stuff like that after you cardiovert. Okay, everybody okay with that? All right. Now take the same patient now in the 160s, but his blood pressure is 130 over 75. Okay, he's a little bit short of breath, right? But, you know, he's 43 years old. He's otherwise healthy. It doesn't bother him. Okay? What do you do now? So we did scenario A, where the guy was unstable. Now he has stable vitals. Okay? Good. So now, right, we give him, now his heart rate is still in the 160, right? Now listen, we're in the acute setting, right? So if I give him amiodarone, I'll give him amiodarone for later, but I got to get his what? I got to get his rate down. Look, he's not going to go home, right? So I'll give him a calcium channel blocker or a beta blocker like esmolol. Some of you guys mentioned that, right? To control what? Rate control. Yeah, I can't let this guy go with tachycardia, right? Rate control. Rate control into what? Give me the rate I want about. What's a good rate? Less than 80. Okay? Preferably like about 70. Right? And if you reduce it to less than 80, this guy says, yeah, doc, I feel good now. Okay? So now you say, okay, I need to do a couple more things for you. And you'll be going home in a little bit. And you'll follow up in clinic in a couple of days. Right? So what are the other couple of things I have to do for this guy? So now I got his heart rate under control. What are the other things I have to do right away? I got to do an echo. Great. Right? Because I got to see what's going on. I got to check a TSH. Right? And maybe anticoagulate. Right? Depending on his risk. Okay? Everybody okay with that? Right? So now, when he leaves, I have a pretty good idea of what's going on with his heart. Does he have hyperthyroidism? Right? And maybe I got him on Coumadin. So now he's on Coumadin and let's say daltiazem. Okay? So now he comes to clinic to see the primary care physician. All right? Primary care visit in a couple of days, maybe a week. Right? He says, doc, I feel some palpitations, but overall, thank you, I feel pretty good, much better than when I saw you in the emergency department. Okay? All right, so now look at this. You have him on diltiazem, right? And his heart rate is 72. He feels good, right? You also started him on Coumadin, 5 milligrams, because he had about 3, 4 points on the CHAD score. Okay? Let's say. All right, so now what are other things you can do for this guy? The echo came back and it was totally normal. Okay? So, all right, one option is to say, okay, listen, you're doing well like that. Let's just leave you like that. Right. So you ask about palpitations and stuff like that. And he says, yeah, there were a couple times, when I really, walked up the stairs really fast and I got a couple palpitations. But generally speaking, I feel good. Right. So that's a good question, Dale. Right. Because you don't want to hear like, listen, every time this guy moves, gets palpitations. Okay. So, so, so one option here is, okay, continue same regimen as above. Right. Everybody okay with that? And what's your other option? There's still another option. There's always another option in medicine. Good. Offer cardioversion, right? And you say, Mr. Jones, you got a couple of possibilities. I shock you, right? Or I give you pharmacologic treatment. Okay? And he goes, Doctor, shock me. Oh my God. That sounds crazy. Okay? And you say, okay, fine, sounds crazy to you. But so let's put you on amiodarone. Okay? But 1 year later, this guy's in and out of AFib. So sometimes he gets a normal sinus rhythm on amiodarone, and sometimes he doesn't. Okay, so you could say, okay, I'll continue amiodarone and diltiazem and Coumadin, and let's just watch him. Or this guy could say, look, I had a couple bouts of tachycardia, that were very disturbing. Is there something more I can do? Something more permanent, right? Not a pacemaker, right? They don't have a problem pacing, right? It's ablation, right? Everybody okay with that? So ablate. So there's still that possibility. I know you meant that, right? Everybody okay with that? So there's still that possibility. So if this guy's not controlled well, I had a patient like that recently. This guy, out of the blue, you get these like runs of AFib, even though we had him on high doses of beta blockers and amiodarone. I say, okay, let's try to ablate him because he's not doing well. He's not stable. If he was stable, I wouldn't mind. Okay, so in this slide, you have kind of like the workup of patients with AFib. All right, you go from starting in the emergency room to long-term treatment. Okay, be careful about this echo. You need this echo here to make a call eventually. This echo tells you if there's a clot in the heart, if there's structural heart disease, what the cause of the AFib may be. That echo is very important. Okay? Everybody clear? All right. Let's look at this case now. A 71-year-old man presents for a routine visit. He has a history of hypertension and atrial fibrillation. Okay? Everybody see that? The atrial fibrillation was diagnosed 4 years ago when he had a transient ischemic attack. Okay, so right away, he's got a CHAD score of like 5, right? He's got hypertension, he's older, he's got a transient ischemic attack. All right, so you're talking about a 4 or 5, right? Okay. He reports feeling well and being able to do all his normal activities without limitation. All right, watch the wording here. He's an avid golf player. His current medications include metoprolol, hydrochlorothiazide, and warfarin, adjusted to an INR between 2 and 3. Okay, sounds good. His heart rate is 68. That's good. His blood pressure, 122/78. The cardiac examination reveals an irregular rate and no murmur. Right? Everybody see that? There's no JVD or edema, and the lungs are cleared to auscultation. The EKG is shown on next slide. All right, let's make sure we read it correctly. What do you guys think? Sam says AFib, right? Everybody okay with that? And if you take like a 6 rhythm strip, it's about from here to about somewhere around here, right? We're talking about, 60 to 70, right? So this guy's looking good, right? The patient has a friend who underwent cardioversion for restoration of normal sinus rhythm, and he wants to know whether restoration of sinus rhythm would be beneficial to him. So you guys get a lot of these questions now. People will see something on TV, they read something on the web, they talk to a friend. Okay, so remember his profile, right? Okay, at this point, what would be the best management option for this patient? So you guys are looking at difficult cases here. See, but you're going to get all the ones in the USMLE, right? All right, see, Mary has a good formula. If it's not broken, folks, do not touch it, right? In medicine, that is a golden rule. This guy's doing well. He's playing golf. He's feeling good. You got his heart rate low. He's having no side effects from medication. Don't touch him. Okay? Okay? Leave him alone. Just continue existing treatment. Okay, now look. If this guy said, look, I'm having bouts of runs of AFib, right? And it's making me feel uncomfortable. I can't live my life. Okay, then you decide to do pharmacocardioversion, vein ablation, external cardioversion. There's a lot of things we could do. Okay? All right. A 25-year-old man who has bouts of atrial fibrillation presents for follow-up. Okay? What do you guys think? If you look at the EKG closer, this is what you see. Right, so this guy has, you go back here, look. Right, remember I said young people presenting with AFib? What do you got to worry about? Wolff Parkinson White. Okay, who knows what the treatment is, so we'll talk about it after the break. But what's the treatment of Wolff Parkinson White? Good. Yusuf says procainamide. You don't want to use beta blockers. You don't want to use calcium blockers. You want to use procainamide. Okay. All right. And then eventually, what do you want to do? So procainamide is good for slowing the heart rate down in these people and controlling it. But what do you got to do eventually in these patients? Ablate the trap. There you go. That's the right answer. Okay, let's take a 10-minute break and we'll come back and finish this up. Looks like we'll probably finish it early. Okay, pretty much done. Let me ask you just a couple questions to make sure everybody understands certain concepts. So why do I want to rhythm control somebody? What are the benefits of putting a person back to sinus rhythm? I know it sounds okay. It it makes sense to put somebody in sinus rhythm, but what are the benefits in a patient with AFib of putting them back to sinus rhythm? So it reduces stress on the heart. But listen, be careful. But does it change mortality? So if you have less stress on your heart, right, because you don't have AFib, do you live longer? So the answer is no, right? So it doesn't. Remember, I told you about those studies that they followed people with AFib for a long time, and they live like everybody else as long as you take care of what? Prevent thrombus formation. That's what you got to worry about. Okay, so think about this. If I put him back to sinus rhythm, and this person stays in sinus rhythm, either pharmacologically, right, or mechanically, whatever, or I ablate them, whatever. What do I gain from that? Number one, I don't have to give them anticoagulation, right? So I reduce my chance of people getting bleeding in the brain right away by taking them off Coumadin. Number two, I take them off medication that I have to rate control him, because if he's in sinus rhythm, I don't have to worry about him going to 160, right? So all that stuff comes off. This guy lives a pretty much normal life. All right, so here's what I'm getting at though. Some patients, we do mechanical cardioversion or pharmacologic or whatever. They go in and out of AFib. So you can't stop the anticoagulation and the rate control right away. If this person goes to sinus rhythm, you have to follow them and make sure they stay in sinus rhythm. So that takes about 3, 4, maybe more months just to make sure they don't go back to AFib. Everybody understand that? Right? So they may have a case like that where they're following that guy. The reason they're following them and they haven't stopped the anticoagulation and the beta blocker, right, is because they don't know yet if this is permanent. Okay? But if it's permanent, then now you're okay. You're free to stop the medication. Okay? Everybody okay with that? There are a lot of cases where you can do that. Most cases, though, you can't. All right? Everybody clear on that? What are the benefits of not trying to rhythm control and just keeping this guy on rate control and nothing else? I know, kind of bizarre questions. Right, no risk of procedures, right? No risk of procedure. Well, futility is, Mary's right. I mean, you bring this guy to the hospital, you try to cardiovert him and stuff like that. The risk of the procedures. Guys, these procedures have a risk to them, right? No side effects from amiodarone. There you go. Okay? That's right. Some patients hate them and they Going AFib. All right. Let's finish up talking about pre-excitation syndrome. Right? They're probably going to ask you about this. All right. Aortic stenosis, aortic regurg, HOCM, pre-excitation syndrome, second-degree heart block, type 1 and 2, third-degree heart block, all over the USMLE almost every year. Okay? In pre-excitation syndrome or Wolff-Parkinson-White, this patient has an accessory pathway. The ventricle is activated earlier. What do you see on the EKG? The short PR interval followed by a wide QRS. Right? So it kind of goes like this. Right? Like that. Okay? Kind of like that. Well, I exaggerated here, but you get the point. That's called a delta wave. Okay? It may cause a fib or a flutter. Be careful, somebody with AFib, you give them diltiazem or beta blockers and their heart rate goes up. That patient probably has pre-excitation syndrome. Do not use beta blockers, do not use calcium blockers, do not use DIG. If you're going to use a medication, use procainamide. The real thing is to get this guy ablated. Okay? All right. A couple more things, and you guys are done. All right. What do we do here? Yeah, pre-excitation syndrome and Wolff-Parkinson-White are one and the same. All right, so you guys see the wide QRSs? This guy's got VTAC. All right, so look, I didn't tell you if he had a pulse or not. So take scenario A, pulseless. Pulseless, VTAC. So that's considered VFib, right? It's like VFib. All right, so what do I do? Defibrillate, okay? And if it doesn't work, I defibrillate again with higher jowls, right? That's the name of the game. Clear, right? So clear. Now that you have these smart defibrillators, where they tell you, oh, be careful, don't press the button, make sure this person doesn't have a pulse, make sure this. Okay, what if this patient has a pulse, positive pulse, unstable vitals? What do we do now? What did we do with AFib? Same thing. What did we do with the guy with AFib? Well, all these guys are getting CPR, right? We're stabilizing the airways. Good. So the answer is cardiovert. Guys, remember we said it, and you guys all told me this. If a patient has a tachyarrhythmia that makes the person have unstable vitals, what do? Synchronized cardioversion. Right? Everybody understand that? Defibrillation is for people that have, which is asynchronized cardioversion. Defibrillation is for people that don't have a pulse. That's VTAC, VFib, right? There's other types of rhythms that are pulseless, but we don't defibrillate those. Pulseless electrical activity, asystole, those don't get defibrillated. VFib, VTAC. Pulseless VTAC is considered VFib. Okay? So they get defibrillator. If the patient has a pulse but is unstable, they get cardioverted. Okay? All right. What if the patient, there's a third possibility. They want to ask you guys that. Yeah. So, well, if it's refractory to cardioversion, you cardiovert them again. You cardiovert them again, and then you could put them on amiodarone. But there's a question there. It's not for you guys. This is like, step 2, step 3 of the boards of medicine, where the guy's got ventricular tachycardia, and he's got a pulse. He's not unstable. He's a little bit, symptomatic, and you put him on medication, right? Because you don't do cardioversion in that guy. And one of the medications you could put him on is on amiodarone. Some of the other ones are things like lidocaine and stuff like that. Okay? Everybody okay with that? All right. What do you guys think about this? The twisting of the points. Torsades, right? So they've asked a lot about this lately. It has to do with prolonged QT intervals, right? So why? Because we now know people are at risk for this prolonged QT interval business, and we give them medication, right? This is a type of polymorphic VTAC. It's a type of VTAC, right? So there's medications that prolong QT interval. But maybe we're causing some of this stuff, right? You guys remember any medication that prolong QT interval? There's a lot, right? But there's some we talked about some antibiotics that do that. The mycins, right? Good. Mary's talked about sotalol. That was a study where it showed that it causes torsades sometimes. Right? Quinidine, right? Tricyclic antidepressants, fluoroquinolones. Okay? All right, very good. So you guys know them. All right. So what causes prolonged QT interval? Well, there's medication, right? There's medication that we just talked about, but hypocalcemia, hypokalemia, hypomagnesemia. I need you guys to know this. Hypothermia, severe, sometimes infections with HIV, sometimes myocardial ischemia and anorexia nervosa, and sometimes intracranial pathology like bleeds in the brain. Okay, now this is your medication, right? You guys got to know this stuff here. Fluoroquinolones and the mycins. Okay, see that? All right, so that's why we don't want to use azithromycin and fluoroquinolones with every viral syndrome known to man. Right, this is a big one. Okay, this is why they're asking this question, because we're treating everything now. If any guy sneezes, we put him on Z-Pak. We put him on Cipro. We put him on moxifloxacin. Not good. Other things that prolong QT, tricyclic antidepressants, lithium, fluoxetine, certain anticonvulsants, but albuterol, right, and levobuterol, antiarrhythmics. Mary talked about sotalol, so that was in the study that when they investigated, and they found sotalol to be a decent drug, right? It caused a lot of QT prolongation and torsades. Flecainide and encainide were taken almost off the market in the 90s because of this, right? And then some other things like loratadine, cisapride. All right, here's what I need you to know out of this slide. From the previous slide, I need you to know hypomagnesemia. In this slide, I need you to know the antibiotics, the tricyclics, right, fluoxetine, and in general, know that antiarrhythmics are also pro-arrhythmic drugs. That's why you don't give them prophylactically when people have acute coronary syndrome. If you know these 4 things, we're good. Okay? They're going to ask a question about antibiotics that prolong QT interval. Okay? Or some question around that. Okay? Everybody okay with that? Okay, very good. So here's your treatment of torsades. This is why I need you to know magnesium, because the treatment is magnesium. You give magnesium, you stop the medication, right? If it deteriorates into VFib, right, then you have to defibrillate, right? That's the three things you got to do. And forget about, okay, you got to keep the potassium elevated normal levels and the magnesium normal levels. That's, no. Okay? No, yes, it does. Yes, it does. Right? So remember I mentioned the study when we were talking about infectious diseases, all the macrolides, right? Remember the study they did in the emergency departments in Canada? So they looked at pre-azithromycin era, after azithromycin, after Z-Pak came out, and they looked at cases of sudden death. And, after azithromycin, it's gone up fourfold, right? This is why people think it has to do with QT prolongation. So listen, macrolides and fluoroquinolones, you guys got to worry about two things, among other things: prolonging QT and effect on some drugs like theophylline. So when people take macrolides and they're taking fluoroquinolones like Cipro or Moxie, right, it affects P450, so you get theophylline toxicity. Guess what? That causes malignant arrhythmias. But we got to keep that in mind. They usually ask questions around those things. Okay? Everybody okay with that? All right. 5-minute review, and then we'll call it a day. All right. So, any tachyarrhythmia that has a pulse but has unstable vitals, what is the treatment? I cardiovert. Synchronized cardioversion. Okay, guys, I know you know it, but listen, if you say shock, somebody's going to say, well, shock is defibrillate too, which is asynchronous cardioversion, right? You don't want to defibrillate. Defibrillate is when a person doesn't have a pulse. You can't synchronize it because there's no pulse, right? Everybody okay with that? So synchronized cardioversion. All right, we got to know the lingo a little bit. All right, when do we do asynchronized cardioversion? Now, you guys are going to take ALS before you start residency. But they don't ask a lot of these questions on step 2 because you're not supposed to have ACLS. But then you're going to have to do it, so you got to know a little bit about it. VFib and pulseless VTAC. Don't forget pulseless VTAC. Pulseless ventricular tachycardia is considered VFib. Okay? Listen, if you're pulseless, Yusuf, you have unstable vitals, my friend. So that's that those things go together, right? Those things go together. Okay, my point is, look, you could have unstable vitals and have a pulse, right? Okay, I know you know. Okay, okay, everybody got that? Okay, and what did I say? You do if you have ventricular tachycardia and the patient's stable. Okay, you still got to get him out of ventricular tachycardia. So what do you do now? Well, you don't. So remember, cardioversion is for unstable vitals. You just don't go around shocking people, right? You rate control with what? That's my point. Good, with medication, right? Amiodarone. So VTAC, mostly beta blockers and calcium blockers, they don't do too well. They're good for AFib, but not for VTAC, right? It's usually amiodarone, it's usually lidocaine, stuff like that. Okay, everybody okay with that? All right. What's the drug of choice if I want to rate control pre-excitation syndrome? What's another name for pre-excitation syndrome? Wolff-Parkinson-White, right? And the answer is procainamide. Okay, what drugs are contraindicated in Wolff-Parkinson-White syndrome? Right, you don't want to give beta blockers or calcium blockers, right? Because now you got more stuff going through the accessory pathways, right? Everybody remember that? Which if they give us a case of AFib and I put this guy on beta blockers or calcium blockers and his heart rate goes up to 160, 170 and this guy crashes, this guy's got Wolff-Parkinson-White syndrome. Somebody missed it, which is okay. Sometimes you miss it. Okay? The rate shouldn't go up. Okay, put him on procainamide. What is the definitive treatment for pre-excitation syndrome? Ablate. Okay? Everybody okay with that? All right. Last thing. Tell me some differences between AFib and A-flutter. Good. AFib can be sustained. Very good. Flutter's transient. Temporary. Okay, that's one. Very good. You don't hear a lot about chronic A-flutter. Okay? Good. Asa says flutter has sawtooth pattern. And how about the RR intervals? Remember I explained about pacemakers going off? Good. Flutter's regular. AFib irregular, right? So you could see that. That's how you tell the difference right away. Okay, everybody remember that? How about the QRS complex? Is it the same in flutter and fib? It's a trick question. They have the same QRS. Listen, they're above the ventricle, so it looks the same. Okay? Narrow in both. Okay? That's okay. All right, which one of the two is easier to cardiovert? Meaning I need the lowest amount of jowls. Flutter. Flutter is very easy rhythm to cardiovert. Doesn't mean it stays that way, but it's easy to get them out of that. Okay? Everybody okay with that? All right. All right, everybody. We are done. Thank you so much for your attention. I'm wishing everybody a wonderful night and the best of luck. And you guys have my email. Please feel free to send me any questions or any thoughts. Thank you so much for listening and for your attention. And Hats, thank you for your help. All right? Take care, everybody. Thanks so much. I hope you guys had as wonderful time as I did with you guys. It was a wonderful group. Thank you so much. Take care.